Dear colleagues, I am Papageorgiou from Thessaloniki, Greece, and I would like to welcome you to this ideas webcast on the differential diagnosis between irritated seborrheic keratosis and squamous cell carcinoma. Seborrheic keratosis are common benign neoplasms, and their dermatoscopic features have been well described in the literature. As a result, the vast majority of them are easily recognized based on their clinical and dermatoscopic features. And this is how a typical SEBK looks like, typified by the comedon-like openings, the milia-like cysts, and the fingerprint-like structures. Moreover, characteristic dermoscopic findings are observed according to the subtype of a SEBK, such as in a lichen planus-like keratosis, a clonal SEBK, a hyperkeratotic SEBK, and a melanocanthoma. However, non-typical cases do exist, including few subtypes mentioned before, and unusual patterns of SEBKs have been described that may, in fact, mimic malignancies such as melanoma, basal cell carcinoma, and squamous cell carcinoma. Correspondingly, the dermatoscopic features of invasive SCCs have also been well described, and they mainly depend on the grade of the histopathological differentiation. More precisely, in well-differentiated SCCs, white is the predominant color as sign of keratinization. White color may be seen either as white or yellow scales and masses of keratin, or white structureless areas, or white circles, or white perivascular halos, or as combination of all these. The colors becomes more pinkish in moderately differentiated SCCs, while in poorly differentiated ones, as the keratinization decreases, we mainly see red color as a result of dense vascularity along with ulceration or bleeding and polymorphous vessels. Regarding now irritated SEBKs, it seems that they tend not to display the well-known criteria. Instead, they may display scales, crusts, and erosions, making their diagnosis very difficult. Moreover, as a keratinizing tumor, an irritated SEBK may share common characteristics with other keratinizing tumors, such as squamous cell carcinoma, especially the well-differentiated one. For example, clinically speaking, these are two quite similar lesions, both of which dermoscopically display scales, erosions, and vessels. However, the left lesion is an irritated SEBK and the right is squamous cell carcinoma. Again here, these nodular lesions, both clinically and dermoscopically, are similar. However, on the left there is an irritated SEBK, while on the right there is an SCC. And since this is a quite often scenario in the everyday clinical practice, what would be helpful for us to differentiate these two tumors? According to this paper, although SCCs and irritated SEBKs share common dermatoscopic features, there are a few characteristics that could help. First of all, the vessel morphology. Although polymorphous vessels may be seen in both lesions, when dotted vessels are present, we should think of an SCC. In contrast, when we see hairpin vessels, we should think of an irritated SEBK. However, the differential diagnosis cannot be based only on this, since hairpin vessels may also be seen in SCCs. For example, in these cases, the main vascular pattern we see is dotted vessels, and they are histologically confirmed SCCs, while in these cases, the main vascular pattern seen is the hairpin, and are histologically confirmed irritated seborrheic keratosis. Additional features that may help, if present, are the white structureless areas and the white circles, which are suggestive of a squamous cell carcinoma. Of course, it has been proved from previous studies that white circles are specific for SCCs, also confirmed in this study and seen in these SCCs. More or less the same for white structureless areas. When present, as in these lesions, they may suggest an SCC. The vessel arrangement and the scale distribution might also provide valuable information for the differential diagnosis between irritated SEBK and SCC. Irritated SEBKs tend to display a diffuse scale and a diffuse regular vessel arrangement as a result of its rather symmetric dermoscopic morphology. as in this sub-K, for example, in which we see the diffuse regular distribution of vessels and scales. In contrast, vessels in SCCs tend to be distributed either peripherally or in a diffuse irregular way, while scales are usually distributed in the center. For example, in this SCC on the left, we see the central scale, few dotted vessels at the periphery of the lesion, and multiple white circles. On the right, although we see hairpin vessels, they are distributed peripherally along with the central scale. Last but not least, one more finding in this paper is about white perivascular halos. We know that white halos are often seen in keratinizing tumor as a sign of keratinization. This is not something new. However, the quantification of this criterion might be helpful. This means that white halos surrounding vessels in more than 10% of the lesion is more common in irritated sub-case, while in SCCs it is more frequent to be present in less than 10% of the lesion, as in this irritated sub-case in which white halos are almost seen in the whole lesion. And one last example, on the left we see multiple hairpin vessels surrounded by white halos in a diffuse regular distribution and diffuse scales, while in the right one we see polymorphous vessels, among which some dotted vessels, a white structureless area, and central scales, and these are reasons for excisions because the right lesion was an SCC. So, in conclusion, irritated sub-Ks tend not to display the typical sub-K criteria. In non-pigmented lesions in which our differential diagnosis is between irritated sub-K and SCC, we should take into consideration first, the vessel morphology. When hairpin vessels are present, we should think of an irritated sub-K. When dotted vessels are present, we should think of an SCC. And second, we should search for additional features such as the white perifollicular circles and the white structureless areas, which are indicative of SCC. Moreover, keep in mind that irritated sub-Ks tend to exhibit a diffuse regular vessel arrangement, a diffuse scale arrangement, and multiple white halos, showing in general symmetry, the symmetry of a benign tumor, while the presence of irregular vessel arrangement, peripheral vessel arrangement, and central scale arrangement favors the diagnosis of an SCC. The last two characteristics have also been described to typify the diagnosis of keratocanthoma. And with this slide, I would like to thank you for watching this webcast.